Okay. So, good evening, all. Today I'm here to give an overview of phonosurgery. Phonosurgery itself is a very huge topic. I cannot cover each and every detailed aspect of it, but I can try to give an overview of what is phonosurgery. Before that, I would like to start with voice. What is voice? Voice is our identity. So, how the voice is produced? It is produced by the vibration of the vocal folds that together leads to form a highly effective, which is an highly effective oscillator. So, what leads to this functioning as an oscillator? How this oscillation is produced? Here you can see this animation where we are seeing the formation of an inferior lip, a mid lip, and a superior lip. So this is the way the mucosal wave is created, and which is creating this itself is creating the oscillation of vocal fold. So this is again a laryngoscopy, a stroboscopy actually, where this mucosal wave movement can be seen in a real-time picturization, in a real-time video. So this sustained phonation of our vocal fold is possible due to the characteristic ultrastructure of our vocal folds. So coming to details of the ultrastructure, how it is formed. The vocal fold has got three layers. The superficial layer is the epithelium, and then we have lamina propria, which has got three layers in between: superficial layer, intermediate layer, and deep layer. So the superficial layer of the lamina propria is known as Rinke space, which is a very important space. Then comes the intermediate layer, and then comes the deeper layer. Deep to the deeper layer of lamina propria lies our vocalis muscle. So Hirano in the year 1974 has described the movement of the mucosal wave on the basis of body cover theory. What does it say? Where the cover, which is formed by the epithelium and the superficial layer of the lamina propria, that is Rinke space, the mucosal wave is created when this covers moves over the body, oscillates over the body. The body, which is formed by again the deeper layer and the vocalis muscle. The deeper layer of the lamina propria and the vocalis muscle. So this is the theory by which the mucosal wave is explained. And on the basis of this ultrastructure, actually, vocal fold surgery, the mechanism of vocal fold surgery is dependent upon. The mechanism of actually the phonosurgery is dependent upon this ultrastructure and this body cover theory. Phonosurgery, which was defined by Hans van Leden together with Arnold. So what is phonosurgery? It is primarily designed, these are the surgeries which are primarily designed for improvement or restoration of voice. So how we can restore or improve, that we will see in the coming slides. So along with this ultrastructure of vocal folds, what are the other structure? The laryngeal framework. The whole laryngeal framework is responsible for producing voice. In the laryngeal framework, there are some skeletal structures, cartilaginous structures like thyroid cartilage, epiglottis, cricoid cartilage, laryngeal cartilage, and there are some muscular structures which are supporting this skeletal structures. So some important intrinsic muscles which are supporting these skeletal structures are intrinsic muscles I'm talking. The important intrinsic muscles are, there are a number of group of muscles of extrinsic and extrinsic muscle, but I want to talk about only or impress upon the intrinsic muscles only. So what are the intrinsic muscle? The most important abductor intrinsic muscle is the posterior cricoid arytenoid muscle. What is the important adductor? Which is the lateral cricoarytenoid. Can you see my cursor? It is the lateral cricoarytenoid. This one is the lateral cricoarytenoid, which is the only adductor muscle, and the transverse arytenoid muscle. What is the tensor muscle which is important? Cricothyroid muscle. We can see in the next slide. And what is the muscle which helps in relaxation of these vocal folds? Which is the thyroid arytenoid muscle. So thyroarytenoid muscle, which is the relaxer muscle, cricoarytenoid, this one is the cricothyroid muscle. Cricothyroid muscle, this one actually. Cricothyroid muscle is the one which is the tensor of the vocal folds. The abductor of the vocal fold is posterior cricoarytenoid, and the adductor of the vocal folds are lateral cricoarytenoid and transverse arytenoid. So our voice is produced by an interplay of uh, agonist and antagonist action of these muscles and this skeleton, along with the mucosal mucosal waves of the vocal folds. So if we try to define the characteristic of male and female voice, it depends on actually the characteristic of male and female larynx. So the characteristic of male and female larynx are more or less close, but there is a little bit difference in the dimension. For example, the length in of the male larynx is about 44 millimeter and the length in female larynx is 36 millimeter. On the other hand, the transverse diameter is again very close, 43 millimeter in male and 41 millimeters in female. So what is the other major difference is the thyroid angulation. The thyroid angulation is 120 degree in females and 90 degree in males. All these factors leads to difference in the fundamental frequency of a male and female voice, which is the characteristic of a male and female voice, where the fundamental frequency ranges from 85 to 155 hertz in male and 165 to 255 hertz in female, a high pitch voice in female. Why I'm going to details on in all of this, because one part of the phonosurgery is laryngeal framework surgery, which actually depends on attaining these kind of pitch when we are doing the procedures. So what are the modalities which are available for doing phonosurgery? It ranges from cold steel dissection to surgical laser to photodynamic therapy to cryotherapy. So what is cold steel surgery? So am I audible clearly and the slides are moving? Can anybody respond? Are you able to see all the slides?
Yeah, ma'am.
Yes, ma'am. Okay. So cold steel surgery, what is the mechanism behind cold steel surgery? This is the biomechanical disruption of the laryngeal tissue or tissue microarchitecture via shear stress, which results in separation of the tissue planes. So what is the advantage? Advantage is the feedback. With the help of the cold instruments, we have our tactile stimulation and we can get a feedback very easily. The depth can be palpated very easily. In fact, cold steel surgery is recommended by a group of surgeons, Zettel et al. They have recommended cold steel surgery in case of T1 glottic carcinoma or any pathology that are superficial to vocal ligament. Because of this tactile feel and the perception of the depth, that can be done with the help of cold steel instruments only. What are the disadvantages? Of course, no coagulative property. If the surgeon has muscle tremor, the tremor will be very much visible and it will lead to the effect on the while dissection. While dissection, the effects can be seen easily and eventually it will the surgeon can get fatigue because of the length of the instruments. We are using very lengthy instruments to reach the actual operating area, and a tremor or any other kind of fatigue will accentuate our movements near the vocal folds. Coming to another modality of surgery, which is laser surgery. Laser can be ablative lasers, which are carbon dioxide laser, YAG laser, or PIRL laser. This is a recent kind of laser, which is picosecond infrared laser. Why lasers are being nowadays lasers are being preferred more and more in laryngeal surgery? Because of the high degree of precision due to small spot size, which are generated by a small focused beam of light. The working area is very small, so this small spot size can help in dissection in the confined area, in the congested area very easily. Sometimes the laser beams or the beams, they do not come directly in contact with the target tissue, so there is not very significant reduction in chances of any infection if it is happening due to the surgery. And also because of the thermal effect of the lasers, that itself inhibits any bacterial growth at the surgical site. So what are the conditions in which ablative lasers can be used? It includes anterior glottic web, granulomas, RRPs, even oncologic resections such as T1 and T2 kind of laryngeal tumors can also be dealt very easily with the help of laser. So non-ablative lasers are again another kind of lasers which are coming in laryngeal surgery, which are KTP laser and pulse dye laser. So these lasers are actually non-ablative laser. They direct their energy at coagulating the blood vessels, so as to the blood vessels which are supplying the tissues. So the conditions which can be dealt with non-ablative lasers are T1 glottic carcinoma and small and superficial lesions of the larynx. Also in other laryngeal disorders like Ranke's edema, laryngeal papillomas, and hemorrhagic polyps. So coming to the next modality of treatment, which is the photodynamic therapy. What is the photodynamic therapy? It actually, the mechanism behind photodynamic therapy is first you introduce a photosensitizer into the tissue. That may be through a topical application, through oral medication, through local injection, or systemic administration. First, you introduce the photosensitizer into the diseased tissue, and then with the help of a typical wavelength, light of wavelength, which is exposed, the area, the tissue is exposed, it leads to development of reactive oxygen species, oxygen-free radicals, which helps in which interrupts in the cellular biomechanisms, and the cellular function is interfered, which leads to apoptosis of the cell. And this way, the tissue is being reduced in bulk. So this is a laryngeal growth, which after photodynamic therapy, these are the serial follow-up pictures after few. This is after 2 weeks, and this is after maybe after 2 months. So here, this therapy was provided, and which is known to be giving good results. What are the advantages? It can be targeted to a specific type of tissue or a specific type of cells. Only the cells which are absorbing that kind of photosensitizer will be affected by this therapy. So what are the disadvantages? The activation or the depth of the photosensitizer substance is very less, which is 2 to 10 millimeter. So it has to be, it cannot be used alone. It has to be added as an adjunct to other type of modalities to achieve good results. It is an emerging treatment in early stage laryngeal cancers, while another group of study where in T1 carcinomas, they have used it as an adjunct. So coming to another mode of therapy, which is cryotherapy. Cryotherapy, we all know the mechanism behind cryotherapy is destroying the tissue by introducing a very low kind of temperature, around minus 197 degrees Celsius, for which liquid nitrogen is being used. So this is the device where through a probe, move this thing. So this is a device where there's a probe, through probe, yes, cryoprobe. Through this cryo probe, the tissue, this probe is made in contact with the tissue, and with the help of this mechanism, it leads in tissue destructive effects by damaging the blood vessels in the capillaries, which eventually leads to tissue necrosis. So what are its advantages? It has excellent healing properties. It results in minimal scarring, which is an important factor when we are considering treating laryngeals here, where we do not want scarring due to any cause. Desirable the voice quality, desirable post-operative voice quality, because it leads to minimal scarring, and it also leads to treatment of some superficial laryngeal lesions like papilloma, glottic carcinoma, and subglottic and glottic stenosis also. So coming to the phonosurgical procedures. So nowadays, phonosurgery is divided into two parts, or maybe considered into two parts, where primary phonosurgery and secondary phonosurgery can be considered. Primary phonosurgery, these are the procedures in which there is improvement or restoration of voice is the only indication for which the surgery is being undertaken. And secondary phonosurgery, these are the procedures where we are doing the surgery for another purpose, for example, for obtaining histology, or following we are trying to get an oncologic margin or oncology purpose, but improvement in voice or restoration of voice is an additional goal which we are achieving by this. So what are the phonosurgical procedures? Primary phonosurgical procedures are vocal fold surgery, laryngeal framework surgery, neuromuscular surgery, and reconstructive surgery. So these are actually the classification of the primary phonosurgery. So I am not going into details of reconstructive surgery here. I'll only be able to discuss a few details about focal fold surgery, laryngeal framework, and neuromuscular surgery. So what is vocal fold surgery? These are the surgical procedures which are performed on the vocal folds with the aim of improving either the vibratory movement of the vocal fold, or the movement of the vocal fold itself. So vocal fold movement, if you want to restore, for example, vocal fold immobility due to paralysis or paresis, for example, in cricoarytenoid joint disorders, in some kind of neurologic disorders like spasmodic dysphonia, in some kind of dysfunctional disorders like dysphonia plica ventricularis. So procedures undertaken to restore the movement of the vocal folds comes under vocal fold surgery. And if we are trying to correct the vibratory motion or the mucosal wave of the vocal fold, that is also known as vocal fold surgery. So vibratory pattern or vibratory movement of the vocal fold may be affected if there is a lesion in different layers of the vocal fold. For example, if it is a papilloma is there in the epithelium layer, and hyperplasia, dysplasia, carcinoma in situ. For example, here, this is the papilloma which is involving the epithelial layer. So this may lead to disruption of the vibratory movement of the vocal fold, and which may lead to hoarseness. Lamina propria, coming to lamina propria, the superficial layer of the lamina propria, which is rinky space, there are number of pathologies which happen in the superficial layer of the lamina propria and thus leads to hoarseness. For example, Rinck's-edema. Rinck's-edema is one such condition which involves the superficial layer of the lamina propria. Bilateral vocal fold nodule is one such condition. Arytenoid granuloma, if at the level of arytenoid, if there is growth due to intubation or due to maybe sometimes due to gross LPR, so that may also come under vocal fold surgery, and that may interfere with the vibratory movement of the vocal fold. So what are the techniques which come under vocal fold surgery? These are sometimes incision, excision, dissection by the method of microflap, augmentation laryngoplasty, or implantation laryngoplasty with the help of injecting some agents can also be considered as a way of vocal fold surgery. So whatever we do in vocal fold surgery, we have to follow the principle of phonomicrosurgery. So the principle is to maintain or improve the functional structure of the vocal fold by respecting its layered structure. And also the other principle is to minimize the tissue excision and minimal disruption of the superficial layer of the lamina propria, keeping the epithelium intact at the vibratory margin. So how we can do this? The techniques which have been developed to follow the principle of phonomicrosurgery is microflap technique. The variations of microflap technique are mini microflap or lateral or medial microflap. So here we can see this is a picture which is showing a cyst at the vibratory margin of the left vocal fold. So following the principle of phonomicrosurgery, this can be done with the help of mini microflap technique, where an incision is is actually taken at the lateral border of the lesion. You can see we have taken this incision here. We can see this epithelium layer and this rinky space where it is involving the cyst is involving the superficial layer of the lamina propria. Here, see the dissection is being carried out and we can see whole of the cyst here. So with the help of a dissection, cold seal dissection, we have removed whole of the cyst here, and now you can see the intact epithelium on the undersurface of the lesion. So now this flap can again be reposited here, and we can see it's not a video actually.
Ma'am, slide is visual, ma'am.
Slide is visible.
Yeah.
Hello. Slide is visible.
Yeah, ma'am, it's visual.
Okay, should I proceed then?
Yeah, ma'am, you can proceed.
Okay, okay. So somebody is posting video is not. I'm not playing any video. This is the screenshot of the structure, screenshot of the steps I'm taking. So now the flap can again be reposited, and here you can see the end stage of the excision. So coming to another procedure.
Ma'am, your voice is breaking. I think there is some network fluctuation at your end. So do one thing, ma'am. Stop your video and continue.
Hello.
Yeah, ma'am.
Yeah.
Stop your video, ma'am, and continue. Again, share
Okay,
the
I
screen.
should stop it again. Acha. Now, again, should I start?
Yeah, ma'am.
Okay.
Good evening, Dr. Nilima Gupta. You may unmute yourself.
Shall I share my screen
Ma'am,
again?
first stop your video, ma'am. Your network is fluctuating. That's why. And continue without your keep your video on.
Hello.
Yeah, ma'am. Now share the screen.
Hello, Dr. Baisakhi.
Yeah,
This is
stopped.
Dr.
I have
Nilima this
stopped.
side. Hello, Dr. Baisakhi.
You're audible, ma'am. Good evening, ma'am.
Yeah, good evening. Dr. Baisakhi, you can start sharing your screen. Hello, Dr. Baisakhi. Hello, Dr. Baisakhi. We can't share. We can't see your screen. I think we've lost the connection. Hello, can you contact Dr. Baisakhi and
Yeah,
ask
ma'am.
her?
Yeah, ma'am. Coordinated with Dr. Baisakhi.
Yeah, okay.
Ma'am, Dr. Baisakhi is joining again.
Okay. I think it is taking her very long to reconnect. What is the problem that she's facing?
I'm network.
Click once on the presentation and try
I'm
to
coordinating with ma'am.
Okay. Okay.
Okay.
continue the chat. Okay. Trainees may type, sir, when we are examination, I didn't got my admit card.
Yeah, ma'am.
Okay.
Yeah.
And
Are you able to see
I'm
my
not
screen?
audible. I'm not able
Huh.
to see, so just ignore all
Full
this.
screen?
In case of any issues, we will let you
No,
know.
ma'am. Yeah, now it's full
Pick
screen.
up the relevant questions. sir.
You may
Address
continue.
these questions fully.
Hello.
Yeah, ma'am. You're audible. You may continue.
Okay. So starting again from where I left. Yeah, coming to. So do you want me to repeat this slide, the last slide?
I don't know, ma'am. Tenny will say the last
Okay,
slide.
okay, see. So, yes, ma'am. Okay, coming to this. So, what I was talking about, principle of phonomicrosurgery. Principle of phonomicrosurgery is simple. It is to maintain or the functional structure of the vocal fold by respecting its layered structure, which we have seen earlier in the starting of our lecture. So, what are the principles? Minimal tissue excision, minimal disruption of the superficial layer of the lamina propria, and preserving as much as epithelium is the only principle of phonomicrosurgery. So, the technique which encompasses or involves all these steps is microflap technique. Modification of microflap techniques are a lot of modifications: mini microflap or medial or lateral microflap or subepithelial microflap. So coming to this lesion, where we can see the left cord is involved by a benign lesion, an SOL cyst actually. So what we, if we want to do microflap over it, so we will take a lesion just lateral to the margin of this lesion after infiltrating in the subepithelial layer 1 ml of our local solution, local adrenaline and lignocaine. So after taking the infiltrating with lignocaine and adrenaline, we'll take an incision. We'll take an incision extending from the anterior attachment up to the posterior attachment. With the help of instruments, we'll try to create a layer, create a plane, preserving the superficial layer of the lamina propria. This is the entirety of the cyst, where we can see here. Now, gradually we'll dissect the cyst from all around, and this is, we can see the undersurface of the lesion. And now, after excision, after completion of the procedure, again repositing the microflap to its original position, we can see the at the end of the procedure, there is normal alignment of the vocal fold, just like the other side. So coming to injection laryngoplasty, this is also a type of vocal fold surgery. This can be done in an office procedure or or in a patient under general anesthesia. Usually this is done for patients with unilateral vocal fold paresis or paralysis. It's a temporary procedure. So what do we do here? The paralyzed vocal fold or the paretic vocal fold is usually augmented or medialized with the help of some materials injected into the paraglottic space or into the vocal fold itself. So what are the materials that can be used? The material what we use depends upon the time for which we need the augmentation. For example, for short-term results, we can inject with gel foam or Addis voice gel, which is the most common type of augmentation material that we use. Collagen by the name of available by the name of Symmetra or Zyderm. Hyaluronic acid, Restylane can be used. For long lasting results, we can inject it with fat or implant it with fat, fascia, or calcium hydroxyapatite. So how it can be done? It can be done through trichothyroid approach or through transcartilaginous approach. So if you are doing in the as an office procedure, am I audible? Just again rechecking.
Ma'am, you are audible.
Okay. So if you are doing it as an office procedure, we firstly anesthetize the skin puncture site with the help of 2% lignocaine and adrenaline, and then making the patient sit with head up. We want to make the patient comfortable. Then 10% lignocaine adrenaline is sprayed over the into the larynx, as we do while doing laryngoscopy. With the help of our flexible endoscope, we are monitoring the site of puncture of the needle what we use. So what are the materials? What is the specification of the needle which we use? Usually 25 gauge laryngeal needle is used and 25 centimeter length. The length of the this is the length of the needle, and this is the syringe which we use for Addis injection. So this can be done through cricothyroid approach. First, after palpating the cricothyroid notch, we can insert our needle through this. This is some picture. So here we are monitoring the patient through fiber optic laryngoscope. So after either we can do it through cricothyroid approach or transthyroid approach. Transthyroid approach is through puncturing through the thyroid cartilage. This is the thyroid cartilage. If we want to puncture through the thyroid cartilage, we usually puncture at a site 1 centimeter from the midline at the lower border of the thyroid cartilage. We palpate the lower border of the thyroid cartilage 1 centimeter lateral to the midline. We puncture, and then we go superiorly. Yes, superiorly toward the area we want to target. So here this cord is paralyzed. So after inserting the needle, 25 gauge needle, which is laryngoscopic guided, we can see and palpate whether we are entering the area. And then usually we inject the material and see how much augmentation is attained at the end of the procedure. Usually over injection is being done because this is a temporary procedure. 25 to 30% over injection is being done, and here this is the augmentation or medialization which we have achieved at the end of the procedure. So coming to the next type of phonosurgery, which is laryngeal framework surgery. We all know that these are the surgeries which are performed on laryngeal skeleton or muscular attachment of the intrinsic muscles which I have studied earlier over the laryngeal skeleton, thus modifying, reducing, increasing the dimension of the glottis or the tension of the vocal fold. So what are the principles? We want to aim the improvement in the vibratory movement of the vocal fold, and we want to reduce the glottic insufficiency if it is there, any vocal fold imbalance. So usually this is a external type of approach, an open neck approach. Usually the complications associated with laryngeal framework surgeries are local infection, hematoma, perforation of mucosa sometimes, perforation of the inner perichondrium of the thyroid cartilage, cartilage incision, or formation of the granuloma at the site of puncture. So coming to the most common type of laryngoplasty that we usually practice, it is medialization thyroplasty, or type 1 thyroplasty, also known as approximation thyroplasty. So the most common type is medialization thyroplasty. So what do we do in medialization thyroplasty? We create a window over the thyroid cartilage at a specific site, which is different for male and female. And then with the help of implants, which may be a silastic block or any other material like Gore-Tex or titanium plates, we can medialize the vocal fold medially permanently. So firstly, an incision is taken. Firstly, we try to mark the marking of the thyroid notch, cricoid, and the laryngeal cartilage, then taking a horizontal incision at the mid-level of the thyroid cartilage. Here we have retracted the superior and inferior flap. This is the thyroid cartilage. With the help of monopolar, we are, see, this is the thyroid notch that we have marked. Now, after exposure of the thyroid cartilage in the midline, we are trying to take a point which is 5 millimeter away from the midline on the lateral side of the thyroid ala, which is the side of the vocal fold which we want to medialize. So coming to this side here, see, this is a template which is specified for the patient which we have taken. So at a distance of 5 millimeter from the midline, we'll take a point, and at a distance of 3 millimeter above the lower fold of the thyroid cartilage, lower border of the thyroid cartilage, we take a window. We'll design a window, and then with the help of Freer's cartilage, we'll dissect and undermine the thyroid perichondrium, inner perichondrium, and then after carving this silastic block, according to the medialization that we want to achieve, we'll carve and then put it in such a way that it is snugly fit. So this is a type 1 thyroplasty, most commonly practiced thyroplasty nowadays. Expansion laryngoplasty or expansion thyroplasty. These are usually done when we want to increase the glottic airway or glottic dimension. For example, in adductor kind of dysphonia, adductor dysphonia. So this time, this is basically lateralization thyroplasty or vocal fold abduction. Vocal fold abduction can be achieved by taking a suture, as we do microlaryngeal surgery during under general anesthesia. We are trying to abduct the vocal folds by taking suture. That can be done with suture technique. Lateralization thyroplasty, how we do? It can be done through a medial approach. What we do in a medial approach, a part of the after exposing the thyroid ala, as I have discussed in type 1 thyroplasty, a portion of the midline of the thyroid cartilage is taken out. 3 to 4 millimeter bridge of the thyroid cartilage is taken out, which is increasing the the dimension of the glottis. And to maintain this, it can be maintained over a titanium plate which is fit here, or it can be supported to maintain the bridge. Here also a silastic block can be kept, or it can be covered, or it can be accommodated with thyroid muscle also to achieve, to keep these thyroid cartilage in place through medial approach. What is the lateral approach? In the lateral approach also, at the junction of the anterior 1/3 and middle 1/3, we take a slice of 3 to 4 millimeter of the thyroid cartilage and remove it, and thus create or widen the glottis insufficiency. Relaxation thyroplasty, these are usually for female to male kind of laryngoplasty if you want to practice. And in case of adductor spasmodic dysphonia, this is a kind of shortening thyroplasty. What we are doing, we're trying to relax the tension in the vocal folds, and thus we are trying to increase the pitch, reduce the pitch of the voice. So female to male transsexual surgeries are usually practiced by this way. This can be again done by a medial approach. Here a portion of the thyroid cartilage with the anterior commissure is retruded back, and thyroid cartilage is sutured in front of it, and thus the vocal folds are at rest, increasing the pitch of the, reducing the pitch of the voice. Sorry. Again, lateral approach can be taken where a portion of the thyroid cartilage can be removed. A 3 to 4 millimeter bridge of the thyroid cartilage can be removed and sutured back with the help of 1,0 proline. Tensioning thyroplasty. These are also known as type 4 thyroplasty and done usually for male to female kind of transsexual surgeries. In case of male to female kind of voice changing surgeries, tensioning laryngoplasty is practiced. It can be done by two methods, either by cricothyroid approximation, where cricoid and thyroid are sutured together to activate the cricothyroid muscle and thus increasing the tension of the vocal folds, or elongation thyroplasty, where it can be done through a lateral approach again, where a portion of the thyroid cartilage is removed, and along with it, type 1 thyroplasty is also done to keep this vocal fold in tension. Similarly, this can be also practiced with an medial kind of approach, where a portion of the anterior commissure along with thyroid cartilage is advanced and sutured. Here in this figure, you can see this is this portion of the vocal fold along with the anterior commissure is advanced, and this portion is sutured with the help of titanium bridge. So coming to the neuromuscular procedures, now these are the procedures which are said to achieve the physiological functioning of the larynx without hampering the voice of the patient. So these are performed to restore the laryngeal neuromuscular structure, to restore motility or tension of the vocal fold. These are usually external procedures done for unilateral vocal fold paralysis or bilateral vocal fold paralysis. So first kind of procedure in case of neuromuscular procedures are suppressive procedures, where for example, in spasmodic kind of dysphonia, there is selective intralaryngeal branch resection, either resection or botulinum toxin. Botulinum toxin is also used to introduce chemodenervation of the branch we want to reduce the function of. For example, in spasmodic dysphonia, this is now only in trial, this thing in animal models. Laryngeal reinnervation. What do we do in laryngeal reinnervation? A foreign nerve is taken and it is connected to a denervated muscle to establish its function, to establish the functioning of the motor end plates and produce muscular contraction. This can be done for recurrent laryngeal nerve, for superior laryngeal nerve, for both reinnervating the motor and sensory function of the muscle. This can be done with an end-to-end anastomosis of the nerves, or implantation of the nerve to the muscle can also be done, or even nerve muscle pedicle can be transferred to the site where we want to achieve the functioning of the muscle. So these are of two types, selective and non-selective reinnervation. Selective reinnervation is usually targeted for a specific muscle that we want to achieve the function of. For example, in case of bilateral vocal fold paralysis, selective kind of reinnervation practiced for posterior cricoarytenoid muscle. We want to achieve the functioning of the posterior cricoarytenoid muscle. So the most common method nowadays people use was advised or practiced by Jean-Paul Marie. According to him, both the adductor and abductor supply of the larynx are restored. How we are restoring the abductor muscle? That means the posterior cricoarytenoid, it is reinnervated with the help of the upper root of the phrenic nerve. The upper root of the phrenic nerve is reanastomosed with the part of the branch of the recurrent laryngeal nerve, which is supplying the posterior cricoarytenoid. The adductor muscles are supplied with the part of the recurrent laryngeal nerve, which is supplying the adductor muscles, is anastomosed with the thyroid branch of the 12th nerve, that is ansa hypoglossal. So in this way, the adductor and abductor muscles of the larynx are reinnervated with the help of using phrenic nerve and thyroid branch of the 12th nerve. Non-selective reinnervation is usually practiced for unilateral vocal fold paralysis, where the main motto is not to retain the function. It is only to retain the tone and bulk of the laryngeal muscle. Another type of technique is muscle transposition, which is cricothyroid muscle transposition, or strap muscle is transferred to the arytenoid. So the last technique which is nowadays being discussed is electric stimulation. We all know electrical stimulation of the posterior cricoarytenoid muscle or the vagus nerve or the ansa hypoglossal. So these nerves or these muscles can be stimulated with the help of electrodes, which can be transfixed over the skin. Again, just this thing about just for the sake of completion, reconstructive surgery. Reconstructive surgeries are usually taken for a scar or webs at the level of glottis. So the scars and webs, as you can see here, this is an anterior kind of web here. This is a posterior kind of web here. So this can be restored with the help of using laryngeal skeel, like here, or posterior kind of glottic stenosis or web after excision. They can be dealt with laminotomy, cricoid laminotomy, and introducing a part of the rib cartilage in this portion to maintain the lumen of the glottis. So these are the reconstructive surgeries that can be taken for anterior kind of web or a posterior kind of web, such as laminotomy, laryngeal keel, posterior cricoid flap, or temporary lateral fixation. For partial defects of and total defects of the larynx, some glottic reconstruction can be done with the help of augmentation, simple ventricular fold flap, or combined ventricular fold with the help of epiglottic flap can be done. Secondary glottic reconstruction can again be done by augmentation or implantation or medialization thyroplasty, or more extensive procedures like sliding flap or cervical flap can also be used to repair the defects of the larynx or pharynx together. Total defects can only be repaired with the help of tracheophageal shunt or laryngeal transplantation. So the take-home message that what we can take out of it is, whenever we are doing vocal fold surgery, we have to follow the principles of phonomicrosurgery, following the believing in the principle of preserving the superficial layer of the lamina propria for achieving good voice outcome out of vocal fold surgeries. Laryngeal frameworks can also be laryngeal framework surgery. When we are doing, the remaining skeleton should be taken into account, they should be respected, and appropriate modality of phonosurgery should be chosen depending upon the lesion that we are treating with. So these are the common questions. Actually, we don't have much time here. So these are the common questions that I have come across in the previous papers. Even I have also encountered this type of thyroplasties again. So basically, laryngeal framework surgeries are under laryngeal framework surgery, there are 4 types of thyroplasties: approximation thyroplasty, which is also known as medialization thyroplasty, or type 1 thyroplasty, where we are trying to medialize the vocal fold with the help of, here, we are trying to medialize the vocal fold with the help of a window made in the thyroid cartilage. This window are of different dimensions. For females, it is usually 8 to 10 into 8 to 10 in this thing length, and 4 to 6 millimeter wide. In males, it is 10 to 13 and 5 millimeter wide. So this window we need to make in this specific site, and with the help of different materials like silastic block or Gore-Tex or Teflon block, we can push the vocal fold medially and achieve the medialization of the vocal folds. Expansion thyroplasty or expansion laryngoplasty is usually done to achieve a wide glottis. That can be achieved through a lateral approach. Through the lateral approach, after exposing to a thyroid cartilage, we are removing this portion of the thyroid cartilage, 3 to 4 millimeter wide block of the thyroid cartilage, and we are mobilizing this portion of the thyroid ala, and thus this vocal fold is also moving here and enlarging the space of the glottis. This is through lateral approach. Medial approach is, we are removing this portion of the midline portion of the thyroid cartilage, and we are suturing this portion of the thyroid, the remaining portion of this thyroid cartilage to this thyroid cartilage, with the help of titanium bridge. And to maintain this gap that we have created, we can use either a silastic block or a sternothyroid muscle. Vocal fold abduction can also be done to increase the glottic space. This can be done a suture technique or resection technique. Relaxation thyroplasty. These are the thyroplasty which are done to usually to reduce the pitch of the voice, done in female to male type of transsexual surgeries. So here we want to reduce the tension of the vocal folds. How it can be reduced? If we reduce the length of the vocal folds. So to reduce the length of the vocal fold, that can be done with the medial approach, where the anterior commissure is advanced or retruded, and the thyroid cartilage is sutured over here. Or again, you can remove a portion of the through a lateral approach, you can remove the portion of the thyroid cartilage and suture the thyroid cartilage with proline, and this will also reduce the tension of the vocal folds and let the vocal fold relax. The last one is tensioning thyroplasty or tensioning laryngoplasty. Here, 2 types of techniques can be done: cricothyroid approximation, where cricoid and thyroid cartilage is sutured with the help of 1,0 proline, 2 on each side. which will activate the cricothyroid muscle, which is the tensor of the muscle, and thus increasing the tension over the vocal folds and thus raising the pitch of the voice. Elongation thyroplasty can also be done through lateral approach. This is the lateral approach. We are here, after removing of the thyroid cartilage, we have to push, do a type 1 kind of thyroplasty and thus increase the tension. And this is a medial kind of approach, where a portion of the, taking a medial kind of flap, the anterior commissure along the vocal folds is advanced, thus increasing the tension. Any other question? I'm not able to see any other video. I'm not able to see. Does puberphonia needs to treat surgically? Yes, if through rigorous voice therapy, if your therapist is not able to reduce the pitch, then it needs surgery. It needs, for puberphonia, you need relaxation kind of relaxation laryngoplasty to reduce the pitch of the voice, or also known as shortening thyroplasty. Thank you, Ashish. Okay, I think
Okay, then thank you, ma'am.
we have finished.
And thank you all for joining this session.
Okay, thank you. Thanks a lot.